This is a 76-year-old man who presented with some low-grade temperatures, sweats, and unintentional weight loss of about 10 pounds over the last several months. The patient had recently been hospitalized for pneumonia and presented to the primary care physician with severe fatigue. This patient is relatively healthy, although does have a history of diet-controlled diabetes as well as hypertension. On physical examination, the patient appeared pale and quite fatigued, and the patient was a bit cachectic looking, although the vital signs were normal. The exam was also notable for enlarged bilateral lymphadenopathy, but no evidence of splenomegaly. The ECOG performance status was 2. The laboratory evaluation was notable for a lymphocytosis with a total white blood cell count of 18 and a hemoglobin of 12, but a normal platelet count of around 300,000. The primary care physician sent peripheral blood flow cytometry, which revealed a population of monoclonal B cells that were positive for CD20, CD5, and CD23, consistent with the diagnosis of chronic lymphocytic leukemia. The patient was referred to a hematologist, and at this time, IgHV status as well as the FISH status were not known. The beta-2 microglobulin came back at 2.6. A bone marrow biopsy was performed, which revealed about 50% involvement by this population of monoclonal B cells. Now, my general impression of this case is that it's a bit of an unusual presentation for a patient with CLL these days. The reason I say that is that the majority of patients now are actually asymptomatic at the time of diagnosis. Their primary care doctor may notice an elevated lymphocyte count and confirm the diagnosis, but the patient is feeling fine. But we do still see cases like this with patients who are more symptomatic at the time of diagnosis. And typically these are patients who have higher risk disease markers. And so when I hear this type of story, I do think of a patient perhaps who has a FISH test that's more high risk, or perhaps an IgHV status that's higher risk. And so that would be amongst the first tests that I would send. The FISH test in this case, I wouldn't be surprised if it revealed either a deletion 17p, which is the highest risk abnormality for CLL patients, or possibly a deletion 11q, which is more of an intermediate risk patient. On the IgHV side, about 50% of patients with CLL will have unmutated IgHV, which tends to be a more steadily progressive form of the disease. Patients typically do require treatment relatively soon after diagnosis, and at least historically with our chemoimmunotherapy regimens, the durability of response to treatment was shorter for those patients with the unmutated IgHV. So this is a patient who sounds very symptomatic. The laboratory values are not terribly abnormal, but there is significant lymphadenopathy. So based on this bulk of disease and the symptoms, this is probably a patient who's going to need therapy very soon.